Good evening, and thank you, Gareth, for the introduction. And ladies and gentlemen, I'm happy to be here. I feel very honored on behalf of the South African National Council to join you, especially at this important era in our country, where we have just launched the current National Strategic Plan for HIV, TB, and STI for 2017 to 2022. The issue of drugs, and especially with respect to people injecting drugs, is very critical within our NSP agenda. And for that reason, it's one of the areas that we work with the Department of Social Development and the whole technical working team to assist in trying to make sure that the issue of drugs find expression within the HIV/AIDS National Strategic Plan. I will just start by giving key issues around HIV, TB, and STI, so that I can give a context to the issue of drug use. That's where we are in terms of our epidemic, having 7 million people living with HIV in the country, 270 new infections per year, and 2,000 adolescent girls and young women infected weekly, with 450,000 new TB infections a year, and TB being a leading cause of death. And I'm sure those of you who are here, you also know that the issue of drugs also play a critical role in the mortality around TB. Many STI infections which are asymptomatic, and of course with our new approach of trying to deal with the issue by trying to close the gaps to achieve the 90-90-90 for HIV and TB, where we would like to see if we cannot have 90% of the people that are living with HIV/AIDS knowing their status. We know that while we project that we have 7 million people living with HIV, not all of them know about their status. And the second 90, making sure that 90% of those that are diagnosed should be put on treatment. And that's why within our NSP, we promote that we test and treat. Anybody who is tested positive should be put on treatment. And finally, for those that we try to put on treatment, we must make sure that they get virally suppressed. And that is going to show, when I outline the NSP, how we would want as a country to get there. So it's very important for us in our NSP to understand our epidemic in this country, so that our response can be aligned to what the epidemic tells us. As we were going through the development of our NSP, we need to focus on what the country tells us where the burden of the epidemic is. And we identified that 27 high burden districts in this country account for 78% of people living with HIV. And note that we have 52 districts in South Africa and 19 districts for TB. They are a burden for 70% of TB, with a significant overlap between TB and HIV. We also identify that we find the microepidemics of key populations within those districts, and injection drug users being one of the key populations that we have found, and therefore we also needed to focus. So our approach to the NSP response is to focus on those 27 districts and the 19 districts for TB with overlap, but also outlining the areas where we find that we have got a problem with key populations, and we also find that they are still found within those areas. We also decide that we'll focus on vulnerable populations to be able to ensure that we reach all those vulnerable populations. And of course, also looking at a combination of approaches using both biomedical and structural approaches, which are going to give us more impact. I will just try to indicate here that in the past NSPs that we have had, we have found that one of the weaknesses of the past NSPs was a more focus on the biomedical approach without looking at what are the underlying factors that are making us not to be able to respond adequately. And therefore, it became very critical that we promote both the biomedical and structural approaches in our response. You should be aware that the evidence that we have, in fact, even the evidence that tells us about the 27 high burden district, the cues that we got was from the biomedical evidence that we have had about the number of HIV-infected people in those areas. But we still lack when it comes to the structural issues that drive the epidemic around those areas. But we are beginning to get there. That is why we thought using a more combination approach to the response would be helpful. We also moved towards a countrywide adoption of what we call geospatial mapping of high burden areas. What we do is that within the 27 districts themselves, we also granulate, we profile those areas and granulate to the lowest level to understand better why is this area a high burden area. So that when we look at a particular district, not the whole area in the district will give us an idea of what's happening. There will be certain things within that particular district which are going to even tell us the more burdened wards in that particular areas, and find out what are the other structural and social issues that happens around that area. And that geospatial mapping gives us an indication of what are the things that we need to do. It could be saying that we have a high burden area, what is the behavior of men? Is there gender-based violence around that area? Are there taverns around that area? What are the other things that you can see? What are the age disparities in that area that makes the epidemic to fuel? So that we can be able to have the responses being very appropriate. This will also be supported by strengthening of multi-sectoral responses at local level for planning and implementation. We believe that implementation does not happen at national level. In South Africa, we are known for having the best policies in the region. But when it comes to implementation at lower level, we are not doing very well. So in the current NSP, we thought it is very important to strengthen the ward-based level of implementation, the multi-sectoral structures that we have at ward level for us to be able to implement better. And one of the things that is found in the NSP is the protection of human rights, because without protecting the human rights of people, without looking at stigma and discrimination, the responses will never be able to get better. So we also used the HIV-TB investment case, which gave us the evidence to make choices and costing the programs, but also understanding the social and social drivers of the epidemic. So this is what the evidence told us about what is going on in our communities around the phylogenetical links of HIV transmission network. And this was a study that was done in KZN in Hlabisa, which indicate to us, don't have a pointer here, which indicate to us that the issue that we know that the young women are infected by the older men. Very young women acquire HIV from men on average 8 years older. But when these women get older, they begin to want to have relationships with their own age groups, but they are already infected. So they also transmit infection to the young men of their own age group. And then the whole cycle goes on. Then you'll find men and women who are over the age of 24 years usually acquire HIV from similar aged partners. And then the whole cycle goes on. And therefore, we need to find a way of capping the transmission at some particular stage, because it becomes a cycle which needs to be kept if we have to understand the epidemic better. And then the HIV prevalence is also found among certain key population groups. The sex workers, between 48 and 72% of the sex workers are HIV positive. We also find that HIV prevalence in men who have sex with men is 28%. for injecting drug users is 14%. That's quite a high percentage that we cannot ignore. And then prison inmates, 23%, people with disabilities, 17%. So we need to move out of our box and not thinking that there are certain particular groups that may not be vulnerable. Adolescent girls and young women, that's a critical group which we have defined also as a key population with 38% of new infections among this group. And orphans and vulnerable children, and then of course, the other thing is men who are very difficult to enroll into care. These are the high burden district in the interest of time. You will just see if you are interested in a particular province, just look at your province and see where the burden is. So you can see Gauteng, KZN, Mpumalanga, Eastern Cape, Free State, Northwest, Limpopo, and the Western Cape. But I know that with Limpopo, when we went to there, they said, no, Waterberg is also one of our key areas. But, you know, because of the way we do our statistics, there is a high burden area for them, but because the population size is small in Waterberg, it didn't show that. But when you go to provinces and you do geospatial mapping by province, they will tell you. The geospatial mapping will tell you where the burden actually is. So these are the areas, 19 high burden districts for TB, and you can see that there's an overlap in the district for HIV and TB as well. Now, this was the strategic approach that we use in our NSP, that we say we are not going to ignore the 52 districts, but we are going to focus intensively for the very robust programs on certain geographic priorities, move from district to the ward level across the provinces. We're also going to focus on key populations and vulnerable groups, and later on in the next slides, I will show you how, as a country, we decided to define our vulnerable groups and our key populations. High-impact combination prevention packages, evidence-informed and content-specific. And I'm happy that WHO has actually indicated recently that we have to put more effort on prevention. Actually, what they propose is that 25% of country budgets must begin to be focused on prevention, because they have seen that when we look at health budgets, a very high percentage of budget is only focused on biomedical interventions, and it doesn't look at prevention programs. So we are not going to be able to reduce the pot if we are just the pot is going to increase. So the burden of disease is just going to take a toll on the Department of Health budget if we are not going to cap all the aspects of prevention, including even the issue of drug use. So we also need to have intensified approaches in high burden districts and strengthen community systems, care and support, protecting human rights, stigma and discrimination. So these are the goals of the new NSP. I wouldn't like to bore those people who are already quite familiar with the NSP. I just assume that everybody, because it was launched on the 31st of March by the Deputy President, I'm assuming that everybody is aware. If not, you can go to the website and go through all these NSP goals. But one of the few goals that are quite key in the new NSP, which were not there in the previous NSP, is goals 6, 7, and 8. The issue of leadership and shared accountability for sustainable response. It doesn't matter whether you talk about which particular area of the NSP. If you're not going to get leadership in the response on the ground, the NSP will never be achieved, the goals will never be achieved. And leadership happens at all levels. It cannot just be sitting at national level, and it does not cascade to the district, to the ward level. So everybody at that lowest level is very important to take responsibility. Any person, a family becomes a leader, a community becomes a leader in that response. And I think it's the same way as you would want to deal with the issue of drug use, not just HIV as a single epidemic. But even when we talk about drug use, if the communities are not going to be the ones that respond to that particular epidemic, we are not going to be able to reach the goals. The other thing is the issue of resources to support the achievement of the NSP goals. So with this current NSP goal, we are taking this resource mobilization very serious. We are currently working on our provincial implementation plans, on the district implementation plans, which will be informed by the ward-based kind of targets, because the targets must come from the ward to inform what is happening in the districts and then going up. So these are the critical enablers, but I just want to come to this particular slide. The focus on impact, it's important for us to look at where the epidemic is, who is affected, the specific needs, and that is going to inform you of the package that you can be able to develop. And these were the key and vulnerable populations. The people who use drugs were identified as a key and vulnerable population. And of course, the coordinating mechanism for SANAC for the purpose of response, you can see that the community is the center, and then you have got all other role players that you are going to be happening. Then this is the web that we believe is the web for drug use. The drug user also at the center, and we find that most of those role players, the MSM, sex workers, all of them, the common denominator is that most of them are a key population for drug use. And then, of course, for key points for people using drugs is that HIV is 7 times more likely, they are more likely to die from tuberculosis compared to other people with HIV. And about 1 in 5 people who smoke heroin and methamphetamine will start injecting drugs as well. And there's no accurate population estimates for people who use drugs, but these populations are present in most urban communities because of unprotected sex and sex work, which further increase the high risk among these particular groups. So the milestones that we have is that we have done a lot of advocacy with government and Central Drug Authority. We are part of the technical working group. There's a need for buy-in from government and civil society. The new NSP calls for targeted comprehensive prevention. There's a need for resources which should be available for this work to be able to be moved forward. Of course, support for the development of the new National Drugs Master Plan. We're working with the Department of Social Development on that. The next step is to have an HIV prevention strategy for the people who are using drugs and other people who use drugs as well. Of course, we also need to increase resources for this particular group. And of course, the vision for the NSP is towards a generation free from the burden of HIV, TB, and STI. And the move for us is that let the actions of everybody count if we are able to be able to reduce the new infections. Thank you.